channel. Today we have the challenge to understand what happened to Bettina in 2019. Let's remind you that there is an old debate, as old as science, between lumpers and splitters. Lumpers prefer to encompass several entities, related entities, under an umbrella term. Meanwhile, splitters like more to separate, to distinguish among different processes that have a predominant symptom or characteristic. And this applies very well to autoimmune encephalitis. Today, there is a trend to differentiate among autoimmune epilepsy, autoimmune dementia, and autoimmune psychosis, for example. But this is still an open debate. In 2019, the very same year as Bettina suffered from her strange disorder, a group of experts from the north of Europe published this seminal paper in Lancet Psychiatry. This is a position paper that highlights the concept of autoimmune psychosis. They gave an approach to the diagnosis and treatment. Basically, they considered that there is a subset of patients with new onset psychosis that have inflammatory and immunological abnormalities, and they also present some neurological symptoms as seizures, cognitive decline, movement disorders, and autonomic dysfunction. Well, and what is the evidence? What do we know so far about the relationship between psychiatric disorders and inflammation? Well, regarding psychosis in general, we do know that they tend to occur near infections. There is a very well established relationship between an increase of the expression of some pro-inflammatory genes and microglial activation in these patients. There is also an increase in the level of some serological biomarkers of inflammation, as interferon gamma, TNF-alpha, TGF-alpha, CRP, and some interleukins. On the other hand, we know that there is hypofunction of the NMDA receptors in schizophrenia. Then we know that some classical autoimmune disorders, as lupus and Hashimoto, can manifest themselves with some psychiatric disorders, psychiatric symptoms. And finally, some antipsychotic drugs, especially clozapine, which is very effective, have immunomodulatory effects. Speaking about this subset of patients with autoimmunity, we do know that there is an increase of some loci of MHC that are related with inflammation. There is also an established increase of infiltration of lymphocytes in the brain of these patients in up to 20% of cases. There is more autoimmunity in the patients and their families. And finally, the most recent discovery of the antibodies in the serum and CSF of this subgroup of patients. The most important and frequent is anti-NMDA receptor antibodies, which were discovered by Professor Josep Dalmau, with whom we had the pleasure to have an interview in this channel last year. But we can also find other antibodies, especially anti-VGKC complex antibodies as LAGI1. This international consensus established a list of red flags that can make us suspicious of the presence of this autoimmune psychosis. Let's check the list up, and then we can realize how many of them were fulfilled by our patient. The first is fever or infectious process. Our patient had a fever. We don't know if it was due to a undetected infectious process or secondary to an autonomic dysfunction, but any of them should have drawn our attention. New onset or severe headache or change in the pattern of a previous headache. She didn't suffer from this one. The rapid progression of the psychosis, it was clear her case. She developed the clinical picture in 1 month. The adverse response to the antipsychotic medication or the insufficient response to these drugs, we don't know if this was the case with her. The presence of movement disorders, she had obviously facial dyskinesia and probably catatonia. The presence of seizures, she developed some seizures. The focal neurological signs, you can see in the video the sequela of a left facial paresis. The decreased consciousness, she suffered from this one without any doubt. Autonomic disturbance, we don't know. The presence of aphasia, mutism, or dysarthria, she clearly suffered from aphasia. The presence of a tumor, fortunately, we checked it up again and we didn't find any tumor in this patient. The presence of hyponatremia, after rule out that these were due to certain side effects of medications of carbamazepine or SIRS. She didn't suffer from hyponatremia apparently. The presence of other autoimmune disorders as systemic lupus erythematosus or Hashimoto, and finally paresthesias. So as you can see, our patient had many of these red flags. Well, in 2019, this group of experts established certain criteria for the diagnosis of possible, probable, and definite autoimmune psychosis. These criteria are very, very useful, not just for us neurologists and psychiatrists, but for the comparison of research studies among the world about this issue. For the diagnosis of a possible entity, we need an abrupt onset, this is a clinical assessment, and a rapid progression within 3 months. And on top of this, we need one of the following 7 items: the presence of movement disorders, especially catatonia and dyskinesias, the presence of seizures in a patient without history of epilepsy, an adverse reaction to antipsychotic drugs as abnormalities of the heart rate, hyperthermia or increase of the CK, dysautonomy, the presence of a decrease of the level of consciousness and cognitive decline, especially disproportionate to the clinical picture, and finally the discovery of a tumor. If we have at least one of these 7, we can advance to the paraclinical studies. Okay, once we have the diagnosis of a possible autoimmune psychosis, we can go for the probable one, and for this we can ask for the alterations in 3 very good friends, which are EEG, CSF, and MRI. They ask for the presence of one of the 2 following abnormalities: more than 5 white blood cells in the CSF, or the presence of MRI abnormalities on flare, highly restricted to the temporal lobes and in a bilateral location. On the other hand, we can have 2 of the following 3: the presence of oligoclonal bands or high IgG index in the CSF, the presence of EEG abnormalities, especially spikes or spike waves or rhythmic slowing, focal changes, or the most specific, which is the extreme delta brush pattern, and finally the presence of serum anti-neuronal antibodies, but they should be done by the cell-based assay technique. And finally, for the diagnosis of the definite form of the disease, we need the presence of anti-neuronal antibodies of the IgG class in the CSF of these patients, and they should be performed with the cell-based assay technique. They also highlight another important issue, which is that the history of another psychotic or encephalopathic episode which had resolved do not rule out this diagnosis. Regarding MRI, it should be performed in each and every case if there is no absolute contraindication. If the patient has movement disorder, we can ask the study under anesthesia, and we do not have to hesitate about this. Half of the cases are normal, so we do not have to rule out the diagnosis if we find a normal MRI. On the contrary, if we find something, we see hyperintensities in the cortex of the temporal lobes, especially in the mesial temporal lobes bilaterally, but there are also alterations at the frontoparietal cortex, at the cerebellum, and at the basal nuclei. But if we find this pattern, we can think of the presence of anti-VGKC antibodies. On the other hand, we can have alterations at the level of the white matter, and this is very commonly seen after herpes virus encephalitis. And a final caveat is the use of the window. We have to use a very aggressive window to pick up these subtle abnormalities at the gray matter. Here there is no mass effect, there is no contrast enhancement, and very rarely diffusion restriction. If we find diffusion restriction, we can think of periictal abnormalities. If we have a normal MRI, we can ask for a FDG PET. This study is very useful, very sensitive, but it is expensive, and sometimes it's troublesome in our environment to ask for it. We can find extensive areas of hypo or hypermetabolism, as we can see in this case, which has a normal T2 sequence on MR. We can find a very large hypometabolism on the left hemisphere, and this is very useful for the diagnosis. Well, what do we know about the treatment and prognosis of this entity? Unfortunately, so far we don't have any randomized clinical trials to follow, so we have to rely on the experience of the experts on this field. Regarding antipsychotic drugs, we should keep in mind that we have to go slowly and carefully because of the possibility of trigger an adverse reaction as neuroleptic malignant syndrome, and the response in general is poor to these drugs. Regarding the immunosuppressive treatment, we have 3 lines of therapy. The first line is to remove the antibodies as fast as we can. If there is a tumor, we have to remove it, and we can use plasma exchange or intravenous immunoglobulin in this line. The second line is the use of more chronic immunosuppressive drugs as steroids or methotrexate or mycophenolate, or including azathioprine. And the third line is the use of rituximab or cyclophosphamide. Rituximab specifically is being used more and more frequently around the world as a second line, and there are some trials about this ongoing. We have to keep in mind that there is no specific definition about the duration of the treatment and the relation of this duration with the presence, the persistence, or the absence of antibodies in the CSF. So there are several policies on this issue. And finally, this process can have relapses. The relapse rate ranges from 12 to 35%, and it can occur very, very late after the first episode. So these patients should be followed over time. And to finish up, I would like to recall this saying: you don't diagnose what you don't think of, and you don't think of what you don't know. I think that Bettina, in her speech, in her sad clinical history, make us think over that we have to be humble, we have to ask for advice, ask for another opinion if we don't know what we have in front of us. And we should remember that these two specialties, psychiatry and neurology, have the same target, which is the human brain. So see you next week. Bye bye.